Brilliant. Thank you for very hard to follow that. So I thought what I'd do is to do 192 PowerPoint slides for you. So it's quite a treat, actually, to be talking at midday. Normally they put me on at about 4 when people are starting to slump and nod off. But the great thing about sleep is this is about consolidation. So if you do nod off, you're just consolidating what you heard in that last talk, that's all. So sleep is the dominant activity. If you take a newborn, they're asleep for 18 hours a day. And that is not rest. That is for neural pruning. That's for neural development. It's absolutely crucial. So if you then think about a young person who is vulnerable, either because of society or brain or neurology, and their sleep is fragmented, you're missing out on that vital support. So I'm really passionate about the way that sleep disorders can hide. In fact, they can hide because I know there's not been anyone talking on sleep for any of the previous conferences here. So it's really a good time to give an overview. Sleep disorders, I think, are the most significant, obviously because I'm biased, and under-recognised late effect for young people and adolescents who have had brain tumours. So why do I say that? Because they occur 50% of the time. In brain tumour survivors, the rates are higher than any other childhood cancer. And why? I mean, you could all tell me why. It's the direct effects of everything we do. The tumour itself, the cranial irradiation maybe the chemotherapy, maybe the psychosocial sequelae. What a horrible thing, to have life completely turned upside down. All of those things are going to hit sleep. But also, as we've heard, and very similar to the explanations about vision, the brain isn't chopped up into the bit that does sleep. Every bit of the brain is connected through elaborate networks that all help maintain sleep and sleep rhythms. So at the Evelina, I'm really lucky to work in a really big children's sleep disorder team. And it's holistic. We have doctors, we have ENT surgeons, we have psychologists who do amazing workshops with parents with different rare sleep disorders, because every single part of that is necessary. And we think that children who've had brain injury, brain tumours, they really test us, because every single sleep disorder is overrepresented and it gets missed. And how do I know that? Because it gets missed all the time. We are seeing people 6, 7 years after brain tumour who are not, and this is my main point, they're not just drowsy or tired because they've had a brain tumour. Until proven otherwise, they've got a sleep disorder that could be treatable. And that's my main point. So the tumour location is critical. And this is just a kind of quick way of thinking about sleep problems. So basics, we need to exclude medical causes, something that might be causing pain, something that might be causing, whether it's constipation, etc., or the medicine, and review. But it's quite simple sleep medicine, because it falls into, you either have a problem falling asleep, or you have something odd that goes on in the night that wakes you up, or you're too tired during the day. All right, that's at its simplest level. Now, from a medical perspective, reasons for falling asleep can be insomnia, which I'll come into. Can be something called delayed sleep phase. So in fact, your sleep can be completely fine, but in fact, your body clock is living in New York or Los Angeles, and it's really hard to work when you're in the UK. Sleep can be broken, and what can break it? Well, it can be broken by insomnia, but obstructive sleep apnea is really important as well, and massively overrepresented in people who've had steroids, who've gained weight, who've had radiotherapy that can cause scarring to vocal cords. There are things called, there's a sleep disorder called restless legs, which is much more common in anyone who's got renal problems, but also in people who've had brain tumours. And then jumping to the too sleepy crew. So what happens here? You can't be too sleepy just because your sleep is fragmented at night. And this is an important concept. You know, some people might say, well, they seem to sleep 8 hours at night. But I'm not going to accept that as a sleep doctor, because is that good quality sleep? Often that person that sleeps 8 hours a night, we actually do objective testing and we find that every hour, 20 times an hour, it's interrupted by small things causing wakings. So you wake up unrefreshed following that sleep. But then there are actual causes where you are excessively sleepy during the day. And one of these is narcolepsy. And narcolepsy is a sleep disorder that, for me, I don't think of it as rare, but that's because we're the only place in London seeing it. So we have about 200-300 young people with narcolepsy. It's a lifelong neurological disorder, and it's massively overrepresented in children who've had brain tumours or treatment for brain tumours. And there are different types. So why did I say location was important? Well, it is important, and we kind of ignore it, but it's a really useful tool because it enables me to say, okay, if it's been a tumour or radiation around the hypothalamus, then I'm going to be thinking more about narcolepsy or being extra tired, hypersomnia. If it's something more about in the suprachiasmatic nucleus, that's the tiny little dot under the where the optic nerves cross, then I'm really going to be thinking about, so this is the body's pacemaker. This is kind of one of the most important clocks. I'm going to be thinking about circadian rhythm disorders, or problems where melatonin is deficient, or an irregular sleep-wake rhythm. And what about the pituitary endocrine axis? We've heard about this, but from my perspective, I'm interested in obstructive sleep apnea. Has it caused hypothalamic obesity? Obesity is a risk factor for breathing problems at night time. Has it caused hormonal deficiencies that have led to the obesity as well? And then finally, if it's in the brainstem, I'm really interested in that as well, because the cerebellum can lead to hypoventilation, where the brain's drive for breathing is not as good at night. So breaking down each of the separate things, insomnia. So about a third of survivors into adulthood. Many reasons. You have worse cognitive function, memory, and executive function just with insomnia. So forget about all the other things, just with the insomnia. All of those things are going to be worse in someone with or without any medical problems. So it's worth treating. We've got lots of really effective treatments, very specific types of cognitive behavioral therapy, CBTI, and lots of medications, and more every year, that are more and more specific and less likely to make you wake up feeling drowsy and groggy. Central and obstructive sleep apnea. So this is as high as 64% following neurosurgery, particularly high risk in craniopharyngioma survivors, and so rarely looked at and so rarely screened, and yet every single year post-treatment this should be screened, in my opinion. And this feeds into every part of the mission of Helen, which is for ongoing surveillance, right? It's not finished when the chemotherapy, when the surgery is finished. That's the beginning. Diagnosis of obstructive sleep apnea properly is not a questionnaire. It's not about asking someone, do you snore? You actually need objective sleep investigations that take place in a sleep lab. The great thing since COVID is 50% of the studies we do now are in the patient's home. So children will be getting a detailed sleep study in their own bed next to their own teddy bear. We don't need to drag people into hospital. So all of this is possible at scale. Delayed sleep phase syndrome is incredibly common. We see this a lot. And these are children who can't get up for school, but actually during the holidays, they're fine because their sleep rhythms are out. And great modern new treatments for this with these particular strange glasses that they wear. Just for 20 minutes in the morning, it completely resets the body clock and sometimes melatonin at night. But an easy treatment. However, it's very easy. We've seen children frequently who get told that they're school refusing, but they're actually not school refusing. They'd love to go to school, but they only get 3 hours sleep before they wake up and go to school. That's not school refusing. That's not getting enough sleep to go to school. And if you fix the rhythm problems, you can improve that. And hypersomnia and narcolepsy. So again, this could be a whole day's talk. Sadly, it's not. But here's my point. I guess Excessive daytime sleepiness is the single most commonly reported outcome. This is different from being tired and fatigued. This is having a sleep attack, falling asleep even when you're doing an activity you enjoy. So, for example, I never counted geography in that because everyone falls asleep in that. But it's someone falling asleep when they're talking with their friends during lunchtime. And here's the real kicker. Secondary narcolepsy emerges an average of 6 years after diagnosis and 5 years after cranial irradiation. So what's going to happen? You're going to get someone who is suddenly going to be failing, unable to show their potential at school or at university or whatever they're doing, and told, well, this is to be expected because you've done really well because you survived your brain tumor. Might they have narcolepsy? Might they have hypersomnia? So, and unless you're screening every year for at least 10 years and possibly for the rest of their life, how's it diagnosed? You need, I'm afraid, specialist testing. But again, we can still do this at home. We're using a lot of AI and machine learning. We can diagnose this much easier than we could. And it's treatable. It's not easily treatable, but it's treatable with huge benefits. And so that would be a plea. There are lots of red flags. I won't kind of go through all of them, but excessive daytime sleepiness with sleep attacks, unprovoked sleep attacks, when napping starts again in a young child who dropped naps. Sometimes just onset of daytime hyperactivity or irritability can reflect that the person is trying to fight that drive for sleep. Cataplexy is important. We don't always see it, but cataplexy is this unusual loss of muscle tone with emotional excitement. So you hear something funny or you get a shock or a surprise. It might be your head nods. It might be your legs buckle and go like jelly under you. Very brief, but it's a very important sign. Sleep itself can change. You can start to have strange hallucinations and vivid dreams. You can wake up with sleep paralysis, where you feel you can't move. There's a heavy weight pressing down on you. And by the way, in isolation, just before you all come up to me at lunchtime, we are allowed to have these from time to time. It doesn't mean you have narcolepsy. You need to have the whole lot. Okay. Endocrine. Here we go again, weight gain, right? So hormonal control changes that it's to do with leptin and ghrelin receptors, and this changes in narcolepsy as well. But then guess what? The weight gain drives a tendency towards sleep apnea. So all of this, again, points to needing a holistic, multidisciplinary think about sleep. So when people, and this is just an example of what we're using at the moment. This is a headband we are posting out. You wear it for a weekend. We're using machine learning. We think we are going to be able to diagnose narcolepsy like this without coming into a hospital. And this is a grant from Great Ormond Street Sparks that we're doing this. So what can we do better? Because that's what today's about. We can assume that someone with post-treatment sleepiness might have a treatable sleep disorder. We could use standardized sleep questionnaires every year for 8 years in every clinic. Nothing makes me more depressed than people reinventing questionnaires. There is no need for the rest of human existence for anyone to write a new questionnaire. You're just reinventing the wheel that someone else has done, and you're wasting time. And so when I see someone says, well, we've got our own brain tumor questionnaire and it's got 2 questions on sleep. Why? Why don't you just use an existing 10-item one on sleep that you could use for a referral to give you the leverage to say, look, this young person scores above 5 on this questionnaire. You will now see them in your clinic and the NHS will pay for it. So this is what we should be doing, not writing new questionnaires. Craniopharyngiomas are very, very likely to have sleep problems, much more than any of the others. And I think there should be a low threshold for regular referrals to specialist sleep centres. We would not object at the Evelina if we had to review once a year every young person that's had a craniopharyngioma. And in fact, the Marsden is moving to the Evelina to bring our services more comprehensive together, so we will be seeing that whole population. we need to audit that documentation and a bit more research on the natural history, treatment options, and using ambulatory diagnostics to try and keep children and young people who've spent too many days in hospital out of hospital assessing their sleep from home. That's it. Thank you very much.